Hello and welcome. My name is Whitney and I'm an anesthesia intern documenting my journey as I go through my first year of residency. I just finished up my first week of my emergency medicine block that I have during my transitional year, and I'm really excited to talk about it. Up until this point, I've been mostly working with internal medicine and on their teams, so this is my first time not doing something internal medicine related. So it's been different and really fun, and I guess let's just get into it. All right, so to begin our discussion about emergency medicine block, the first thing I want to acknowledge is that it's pretty different than what I'm used to with internal medicine. I mean this that it's different in terms of like the flow of like you actually have to pick up patients and decide who you're going to see rather than just be given a list of patients that you're going to see. So yeah, the flow is different. The workup itself is almost a little bit different in a way, just because there's a different goal when you're in the emergency room versus when you're working in the internal medicine side of things, whether that's in the hospital or outside of the hospital. Even the team structure is a little bit different, just because it's not as much team based in terms of me working with other residents. So that was an adjustment as well. Now, all of this to say, I don't mean like different in like a bad way or anything like that. It's just I'm most familiar with internal medicine and the flow of that. So it's just been an adjustment. This week was really just like starting from square one, and that's okay. I still have 3 more weeks to work through this, and hopefully I'll get the hang of it before it all comes to an end. All right, so we'll actually start off by talking about the schedule because even that is different from what I was experiencing in internal medicine. So, this block that I'm in for emergency medicine is 4 weeks long. And over this 4 weeks, I will work somewhere between 15 and 16 shifts. So, it comes out to about 4 shifts per week on average, we'll say. Now, each of my shifts are going to be 10 hours long. So, it really isn't that bad with, like 4 shifts a week, 10 hours a shift. That's actually a pretty light schedule, especially for residency. The only kicker is there's a huge variation in when your shift could actually start. So we have some shifts starting at like 6 a.m., where you would work from like 6 to 4 p.m. And then there's also other shifts that start at like 9 p.m. So you'd be working 9 p.m. to 7 a.m. So it really just depends on like what time you start, in terms of like what kind of day you're going to have. For myself this week, I worked, let's see, it was Tuesday, Thursday, Friday, Saturday. So those were my 4 days. And I worked from noon to 10 p.m., which isn't actually that bad of a shift. I feel like the only adjustment I really had to make is I'm used to having like my time off at the end of the day, but instead I had it at the beginning. So that was a little bit different, but overall I really can't complain. I like my sleep schedule wasn't thrown off or anything like that. So it really wasn't that bad, thankfully. What's nice about where I'm training at right now is even though our shifts are 10 hours long, we're actually only actively picking up patients for the first 8 hours. So during those 8 hours, you're, like taking in new patients, but for the last 2 hours of your shift, you're not taking in any new patients and you're really just working on wrapping things up for the day. So like you're waiting on test results or like imaging and finishing notes, whatever it is that you need to do so you can be done by that 10-hour mark. So you're not leaving past that or, much past that. As an off service resident, which just means that like I'm not an emergency medicine resident, like in that department, I'm just like rotating in the department. Um, they made it really clear that during our 8 hours, we're supposed to see one patient an hour, which is kind of like a nice goal. As an intern, they're a little bit more lenient with us just because, like everything is new. So they say they don't expect us to see like one patient an hour as like a new intern, but if I was like a senior rotating in the service or something like that, that would be the expectation. One of the senior residents on my first day told me that on his first day of residency, he saw like 4 patients during his first shift. So that was like my goal for the first shift, is just to see 4 patients, which doesn't seem like a lot when you have like one patient every 2 hours, I suppose it is. But it really is a new area where just the whole system is different than what I was used to. And I just felt like a lost all over again. So even though 4 doesn't seem like a lot, it actually filled my time pretty well. And I don't think I actually like left early that day. I think I left at the 10-hour mark. I feel really fortunate that this senior resident actually talked to me about this, saying like, oh, my first day, I only saw 4 patients. He also told me that like as an off-service resident, I wasn't like expected to like like control how many people we were seeing or like hold myself up to the super high standard, right? Like I was just there to learn. And I really feel like that was helpful for me because I feel like that gave me permission to like slow down and actually like think about things and focus on my patients instead of like trying to rush through everything. So I'm really excited. I think this is going to be like a good learning environment over these next few weeks. And yeah, I have 1 week down now, so I'm excited to see like what the next 3 weeks bring. With this being my first week and talking to that senior resident, I feel like I really just focused on the flow of the emergency room and figuring out like my own rhythm and pace with everything there. I obviously like did see patients and did learn, but I feel like with this first week, it really was just like getting the basics down just because it is so different, right? Like there's not like appointment times or anything. You're really just going off of like who needs to be seen. The other difference that I probably won't talk about in this video, I'll probably dedicate that to another video, though, is the actual workup that is done in the emergency room. It is different than internal medicine, and I'm still trying to get kind of like a hang of it, but really all you're trying to do is just rule out emergencies and see who needs like treatment now and who can be seen in like an outpatient clinic or who might need to be like admitted to the hospital for like further workup. So it's different in that way because I feel like I'm used to like getting exactly to an answer and like working things up, but I'm not used to like being the person who first sees them and like trying to figure out like where they're supposed to go. So that's a bit of an adjustment. I am working on it and hopefully I'll get back to you at some point before this rotation ends. All right, so to talk about the flow of what I've picked up so far after 1 week of emergency medicine is I think the biggest thing is that, like there's not like a list of patients that are given to me that I get to see. I actually get to like look through the list of patients to see who needs to be seen and then decide like who I see. If you're an actual like emergency medicine resident or physician, I don't think you're like going through and picking, but they said as an off-service resident, I could kind of do that. So if there's like a patient who had a problem that I really wanted to see, I could like prioritize seeing them versus someone else. So the way that like I would pick up patients or like see what brings them in, I would just go to an electronic board on the computer that just lists all of the patients that haven't been seen by a physician yet. So on the board, it just has a list of patients who are in the waiting room or waiting in like an actual room and are just waiting for someone to come see them. And all it lists is their name, their age, and their reason for visit. And the reason for visit is super general. So it'll be something like chest pain, which, like when you hear chest pain, there's like a bunch of different things that can cause that. So, like, you have no idea. So, yeah, like chest pain is one. There was one that I saw that was like extremities, which just meant like there was a trauma or like an incident where someone's extremity was like hurt. There's also one called like GI abdomen, which obviously had to do with like abdominal pain, but there's like so many ways that, someone could be hurt that deals with their abdomen. So it's like very, very vague. And that's essentially like all the information that you have before going in. So what I would do is I would just look through the list and see which was interesting to me. And then I would sign up for that patient. And if I could, I would try to do like a quick chart review to see if they'd been seen before by us or, like hospitalized recently. That's actually like really helpful if someone's coming in after being hospitalized or being discharged from the hospital or, was just seen in the emergency room like a week ago. That's like really helpful for us to know. So I'll do like a mini chart review and then I'll just go into the patient's room. I usually don't have a lot of information, but I just go in there and talk with the patient. It's been kind of fun because I feel like with internal medicine, usually you're like chart reviewing really thoroughly and you're trying to figure out like you're trying to build off of other people's ideas, I guess you could say. But on this one, you're the first person to talk to them. So it's really like your thinking that has to go into this to figure out like what's going on with the patient and what kind of workup you want to do. So it's kind of fun because like there's a little bit more, I guess, autonomy in that way because you're the first one to think about it, but it is kind of nerve-wracking in a way because you're the first one to think about it too, and you're not really like building off of any ideas. You're kind of like the foundation level. So it's exciting, and I can say that I'm really glad that I'm just an intern on this and that I always have an attending to go to if I have any questions. So yes, so after I, like sign up for the patient, go talk to them, do the physical exam, I'll then go and present to an attending and go over everything that I found out about the patient. And from there, we come together to figure out like the plan and what we're going to do for the patient. So it's similar to internal medicine in that way, to where I'm still working with an attending. It's just the presentation style and like how I'm actually like learning about the patient looks a little bit different when in the emergency room. Then, once you have your plan all figured out after talking to your attending, then you put everything into motion and you're actually, like ordering all the things that you need to order for this patient for either workup or treatment. So, you're putting in like labs and imaging results or, like fluids, whatever the patient needs in that moment, you're actually doing it there. And this is where another difference between IM and emergency medicine comes into play, because usually with IM, when like order all those things, usually it takes a little bit more time to where you're not expecting the results back super quick, I should say. So, like in the inpatient setting, sometimes you'll order a lab and you'll get it later on in the day. You might get it tomorrow. In the outpatient setting, you might order it today and then look at that results when you see that patient again in like 2-3 weeks, right? Like, so there's a lot of time that lapse between when you order it and when you actually see the results. In the emergency room, it's actually like completely different from that. It's like opposite, because once you order something, you're like looking for the results as soon as you can, just because sometimes patients really need to have those results in quickly and you need to like make decisions based off of those results. So that was another thing that was different, because like once we talked about it, like you sit and then you wait for the results, and the patient doesn't leave until you have the results back. So that was something a little bit different, because I'm used to like just showing up and the results being there, while here it was like, no, I had to like actually look out for the results, which was different. Okay, so I know I said that you're like sitting and waiting for results, but you're not like truly sitting. You're just waiting for the results. So you're usually like doing other things, but you're on the lookout for the results. So every once in a while, you'll like come back to your computer to see if like, oh, are those labs in? Did I get that x-ray back? Just because you need to be on the lookout for it. Sometimes once all the results and everything come back for a patient, that's all you need to determine like what's going on with them. And from there you can decide like where they're going to go home, where they're going to be dispo is what we call it, like where are they going once they're out of the emergency room. And other times that's not enough, and sometimes you need to order more tests based off of those initial ones. So you just keep doing this until you get to the point where you figure out like what are we going to do with this patient. So, for actually ending an emergency room visit, what you'll do is you'll continue your workup until you figure out what you think is going on with the patient, and like figuring out like where are we going to send this patient from here. Now, there's some patients who, they come in for an emergency and we find out that they have like nothing wrong with them. They're like, all of their vital signs are okay, whatever concern they had, we've, ruled out all the like the big scary things. So we feel comfortable sending them home. There's other patients where, they come in with this complaint. We don't think they have like a true emergency. Their like vital signs are stable. We don't think there's like any danger in like not treating them here, but we don't know exactly what could be going on. So like let's say someone has like abdominal pain and we've like ruled out all of the big scary things, but they're still uncomfortable. In those kind of cases, instead of sending them home and saying like, okay, you're free to go, for those patients, we'll actually recommend that they follow up with a provider. So we always say like after you're in the emergency room, always follow up with your primary care person or physician in like 1 to 2 days after you leave the emergency room, just because like we really want those people to like follow up and make sure that they're still doing okay. There's other patients though where they come in with a complaint, we can't exactly figure out what's going on, and they're not hemodynamically stable or like safe to send home, right? So like something's off with their vital signs, or like, they have that chest pain that we can't like really figure out exactly what's going on. It doesn't look like they're having a heart attack, but it's still like just a little bit concerning. Those kind of patients will actually admit to the hospital. And that just means that they're just going to be hospitalized and have further workup and evaluation. That just might take a little bit more time, right? Like when you're in the emergency room, you don't want to be spending all of your time there. You'd much rather be actually in the hospital in a room with a dedicated doctor who could like follow you for multiple days. So those are kind of like the three ways that a patient can exit the emergency room. And it's our goal to figure out like what is the best route for the patient, because sometimes it's kind of blurry. You don't know if like someone should be hospitalized or if they could just follow up outpatient. So that's a lot of like what our workup is working towards. All right, well, that is the general overview that I have for you all for my first week of emergency medicine. I still have 3 more weeks, so I'm hoping to go into a little bit more detail about what the shifts look like. But just for now, I just wanted to start off with just a general overview and look at it. So now let's go ahead and look at how many hours I actually worked this week. So I'll go ahead and pull them up here. And looking at it, yes, I did have Sunday, Monday, and Wednesday off this week, which was really nice. I think I actually took a nap in the afternoon on Wednesday, and I feel like that's just always the best feeling. So I was able to do that this week. So I'm really excited and happy about this rotation so far. But getting back to seriousness, yeah, so Tuesday, Thursday, Friday, and Saturday, I did work full days pretty much. I got off a little bit early on Thursday and Saturday, but getting off at 9 really isn't that bad. So I worked a total of 38 hours this week, which I was actually very doable. I'm actually feeling pretty refreshed right now, so I can't complain too much. All right, well, thank you so much for joining in today's video. I will be back next week after I finish my second week of emergency medicine, and I'll see you then. Take care, everyone.